We'll try to keep this as a practical tips and a case-oriented talk. And so, Dr. Bhattacharya, go ahead and get on with it.
Thank you, Dr. Punamia. My top 5 tips and tricks to get better guide catheter support. This is a session where we are discussing a situation where stents won't cross. Guide catheter, we all know that backup is the key in guide catheter, to cross with wires, to cross with balloons, and to advance stents. The orientation of the origin of the coronary arteries, the left main takeoff and the left main length, the target vessel takeoff, and the aortic root size, all of these are important when you consider a guide catheter selection. Orientation of the origin of the coronary arteries, vessel takeoff, and aortic root size, these are the common orientations. The basics, of course, is an optimal strategy is 90% of the procedure. There is a balance between support and aggressive intubation. We should not be forgetting differences in inner lumen, certainly in case of bifurcations, and we should not forget the 7 and 8 French option. These are common guide catheters in the anteroposterior views, the JL, the AL, and the EBU. So my first tip is when you are going for the left, always start off with the extra backup guide catheter. So this is how I start. I take the XB and I inject into the aorta, and the reason for this is to see the aortic size, to look at the coronary sinuses and the orientation of the takeoff of the left coronary artery. And then I engage and look at this picture. This is the extra backup 3, and as I'm engaging, the catheter backs out. It automatically tells you that there is not enough backup. However, I do the left anterior descending artery because the wire goes in very easily there. And after finishing it, when I try to do the circ, when I try to do the marginal, I again face this problem. So I go for a bigger backup. This is an XB 3.5. And you can see that immediately the backup is much better as it is resting on the aortic cusp. Again, when I try to wire the marginal, the guide catheter backs out again, and this is sometimes a problem when you try to do the circ. So what I do in these situations is I pass a guide wire into the LAD, I let the guide catheter back out a little bit, I put a bigger curve to go into the circ, and once I'm in the circ, I take that other wire out and follow this wire and go to my target vessel. And after that, the angioplasty is very simple.
Can we turn the lights down, please? Can't see this.
Oh. I think this light also we don't really need. This one?
Please get the lights off the face of the speaker, please.
Okay. So when to choose further backup? This is a case where we have a CTO of the circumflex artery. We started off with the XB. And look what happens. This is an intermediate wire, and we are trying to cross it with balloon support, and you can see that the wire, the guide catheter is backing out. So we change it to a AL1. We take a stiffer wire. This is a CTO wire, and we cross it. And then after finishing the angioplasty, we see that there is a side branch that is not patent. So this catheter gives you so nice support that you can go in through the stent into the side branch, and you can take a balloon down it. This is a 1.5 balloon, and this is a reasonable result, I think. So you have to decide early which guide catheter you choose so that you don't have too much trouble, especially in CTOs. Now, there is an impact of the long left main and the short left main, especially when you're doing circumflex. So I will show you one technique that I use to cross the circumflex and obtain good guide catheter support. So this is a female patient with a stenosis in the circumflex artery, and you can see that the left mainstem is quite long, and the circumflex is at a 90-degree takeoff from the left mainstem, maybe a little more than 90 degrees. And sometimes it is very difficult to wire this circumflex. And the wire automatically wants to go into the LAD. There is a big, the left main caliber is very big. And the bend that you put on the wire to get into the circumflex sometimes defeats the purpose, and the wire whiplashes out of the left mainstem every time you want to go into the circumflex. So I put a wire in the LAD, and once you do that, it allows you to just get the guide catheter out a little bit without completely losing the guide catheter position. And then you take another wire and go into the circumflex, put a bigger curve on it, and once you're negotiating that bigger curve, the guide catheter doesn't back out completely. So after you have done that, your wire is in the circumflex now. I take another wire, and the reason for this is this. Look at how the stent goes in. I tried with one wire, but the stent just wouldn't go. So after adequate pre-dilatations, this is a Endeavor Sprint stent going in, and you can see that as you push the stent into the circumflex, the wire over which you are pushing is actually wanting to back out. And if there is only one wire here, everything will fall out, as it tended to do. But you have the second wire acts as a buddy or an anchor, whatever you want to call it, and it helps you in positioning the stent. And once you have got it, the rest is easy. So you stent the circumflex, and that's that. And this is another case showing the same technique. This is a CTO of the circ, but not exactly a CTO, but a occlusion, and again you can see that there is a right angle takeoff. Very difficult to get the wire in and push it across the lesion without losing your guide catheter support. You can see that the guide catheter backs out as you try to manipulate this wire. But this wire in the LAD, it gives you an anchor, and you don't lose your guide catheter position completely. And once you have crossed it, the rest is easy. And a big stent is also, we can put a big stent down the circ without losing the guide catheter position. Sometimes when you're doing a CTO, and this is a CTO in a LAD, within an LAD stent, a restenosis, which is actually a CTO, and you get good guide catheter backup here. This is an intermediate wire. This won't pass. And the only way here to increase your guide catheter backup is to put a microcatheter in and go for a stiffer wire. And once you have done that, you change the wire once you have balloon dilated it, and the rest you just finish off by stenting. Now the right coronary. There are various takeoffs of the right coronary. I won't be able to address all of them, but these are some of these common takeoffs, transverse, superior, and inferior. And these are the common guide catheters that you use, and I will show you some cases to demonstrate. Now this is a right coronary artery where you can see that the origin of the right coronary, the takeoff of the right coronary artery is abnormal. It is high up, and there is a bend just after the proximal part of the ostium, and it is very difficult to negotiate wires across this if you don't have good guide catheter support. You can see. So in this situation, what I choose is I go for a catheter that will sit into that ostium, and this is a AL1 guide catheter. And you can see once you're in the coronary, nicely engaged, it gives you a very easy wiring. Because this is a abnormal takeoff, I take 2 wires before I pass the stent in, and once I have done this, the stenting is easy. Now this is a technique that I use when I lose sometimes the position of the catheter in the coronary ostium. And this is what happens. This is again a CTO-like lesion, and it is actually a CTO. Okay, so watch what happens. I have passed the wire, and now as I was trying to exchange balloons and stuff, this guide catheter, this wire backs out. And you can see that the guide catheter is up, floating in the aorta. Now sometimes if you try to negotiate the guide catheter over the wire back into the coronary ostium, you can lose everything. So what I do usually in this case is I pass a very small, this is a 1.25 balloon, I pass it across and cross into the coronary, and then I follow the guide catheter over the balloon into the coronary ostium. And by using this technique, when this happens both in the right or in the left, I never lose the wire position. And then the rest of it is routine. So we end up stenting it. So how to increase guide catheter backup by deep seating? Again, this is a very important technique. It is a little risky, and I don't recommend that you use it unless you get someone to show you how to do it. This is not my case. I came into this case later, and this is, as you can see, this is a CTO, and it has been crossed by a miracle wire, and the balloon wouldn't go. So you can see that this is again a 1.5 balloon, and you can actually follow the balloon, and you should do it really very gently, and you should not force your way in. And you can see you can deeply intubate the right coronary artery, and you can see the bend in that right coronary artery, which is now resting on the other wall of the aorta, which is giving you very good guide catheter backup. It is almost like an Amplatz catheter now. But again, one should be very careful while doing this, and for first time you should get someone who has done it to show you how to do it. Now, when not to choose an Amplatz guide catheter? This is again a very complex stenosis in the proximal part of the right coronary artery, and you can see this is the JR 3.5 guide catheter, and the operator who was doing it, he couldn't cross, the guide catheter was backing out every time. So we opted for a hockey stick here. I didn't choose an Amplatz because you can see there is osteal disease here, and if you choose an Amplatz here, there is a very real risk of damaging the ostium. What happened with this hockey stick catheter is it just went across the stenosis into the proximal part of the RC, and this you cannot do with the Amplatz. The Amplatz just sits on the ostium. It's much more riskier to do this with the Amplatz. However, when you get a good guide catheter support with the hockey stick here, you can cross the lesion, and then this is a couple of stents going in, and you can complete the job quite nicely. This is again a case of a right coronary artery, and this is, I'm going to show you, this is a very complex lesion. It looks simple here, but it is not at all simple. The lesion is calcified, and when you look at this artery, not in this view, but look at it in this view, you can see that there is an acute bend in the artery, and it is very difficult to wire this artery with this. So you have to, in these cases, we cross this, and what I do is I take the wire very gently, and I let the flow take the wire rather than trying to do too much manipulation. And once you're across, I take a couple of wires in because I know that there is going to be trouble. And you can see, this is a non-compliant balloon. I take a non-compliant balloon because I see that there is calcium in a tight lesion, and I won't be able to get a stent across. And you can see that the non-compliant balloon is very difficult to get it across that lesion. And anyway, we get it. Now see what we are doing. After we had dilated with a non-compliant balloon, when I take the stent in, I gently advance, intubate the catheter over the stent into the right coronary artery, and then I take the stent across and stent it. And once I have done it, I have to post-dilate it. I'm sure I need to post-dilate this stent, but look at what is happening. The stent doesn't want to go across the bend, and this stent I have deployed at 16 atmospheres, but still it doesn't want to go. I know that there is under deployment in the middle of the stent, and it is only after I have deeply intubated the guide catheter into the stent. Again, this has to be done carefully because you can really damage the stent if you're not careful. And then you can actually do this and obtain this final result. And when you are doing the occluded chronic CTO of the right coronary artery, you can also use the mother and child technique. This is a case from one of my colleagues. I borrowed it from him because I do not use the mother and child technique too much. And again, you can see the principle is really same. You have to increase your backup, and here the balloon won't pass, so he has taken the mother and child deeply into the RCA. And I would say that this is a safer technique rather than deep throating the guide catheter. And after you have done this, you can go ahead and stent it, and it's quite a good result. I'll finish off by showing you a couple of interesting cases. This is a case where both the right and the left coronary artery origin are abnormal. You can see from this aortic shoot that the right doesn't arise from the right coronary sinus and the left doesn't arise from the left coronary sinus. And here you have to choose your guide catheter imaginatively. In this case, this is an extra backup going into the right coronary artery. And it gives you reasonably good backup support. And once this soft portion of the wire is in the distal RCA, you can really get your guide catheter backup inside into the right coronary artery. And then you can see the rest is easy. You just stent it. And this is a AL2, and this AL2 guide catheter, again, this is an abnormal origin of the left coronary artery. And here what I want to stress is we are going to do the circ here. And look, if the left mainstem is short, if you are using a AL, then you can actually guide the mouth of your AL guide catheter towards either the right or left. And I have found it very useful while doing circumflex. See how the AL looks into the circumflex artery. And if this is the case, then you can do a good job with very good guide catheter support. This is a case where aggressive intubation and aggressive guide catheter support doesn't work. Look at this case. This is an extra backup 3 guide catheter, and you can see the dense calcium both in the LAD and the circumflex artery. Don't do aggressive intubation. Don't try to ram your way. See how the IVUS catheter gets stuck in the proximal LAD. What you need is this device. And I'm sure there will be more presentations on this. So what I want to make the point is that if you are, in some cases, the guide catheter, aggressively changing the guide catheter to one which gives you more support can actually cause you more trouble. And you see that after you have done it, this artery looks much better. And this is actually a Taxus Liberty stent. And you can see the 3x38 Taxus Liberty stent, implanting it is in no problem at all. So my 5 top 5 tips are: assess aortic root takeoff in the beginning by doing the root angiogram through the guide catheter oriented either towards the LCA or RCA, upsize or downsize or choose a different shape as required. Often the circumflex, or less frequently the LAD takeoff from the LMS, is at an awkward angle. Pass second wire distally in the less angulated vessel to stabilize your guide catheter. If during course of balloon exchange, guide catheter backs out inadvertently and there is a loop formation of the guide wire in the aorta, re-engage the guide catheter by first passing a small balloon over the wire loop into the coronary ostium and follow the balloon instead of trying to re-engage the catheter just over the guide wire. In CTO, increase your guide catheter support by using a microcatheter. In heavily calcified lesion, it is better to shave off the calcium than aggressive guide catheter intubation. And learn how to deep seat a JR 3.5 guide catheter from an experienced operator. Otherwise, use mother and child catheter for difficult stent delivery in right coronary arteries. Thank you very much.
That was very nice and eloquent. Any questions we have for Dr. Bhattacharya?
Yes. You see, this is only 10 minutes, so I didn't have the chance to do the radial. Maybe if I'm asked to do it next year, I'll tell you about radial. The radial is absolutely, totally different, and it depends on the takeoff of the subclavian from the aortic root, and that is a crucial decision making. But the first principles are same. You take a guide catheter. In radial, you have to see how the takeoff of the subclavian is, and that plays an important part in your choice. Where the takeoff is not angulated, in left coronary I take the XB3. The right, most of the time I can engage with a JR 3.5, and I use the same principles. Where the left coronary takeoff is high in radial, I use an Amplatz.
This mother and child which you showed, was it a guideliner or it was a small? It was a guideliner. So that's one of the wonderful catheters that we have and can be used to increase the guide catheter support in such patients. The one more point which I would like to make is sometimes when you are doing CTOs, when it's difficult to cross, you can use a technique called anchor balloon technique to cross it to increase the guide catheter support. And there is another technique which is called a distal buddy balloon technique, where the stent is not going, but you can put the balloon distal to the lesion, inflate it distally, and then put another wire and put your stent over it. And this is a complicated technique, and it has a potential of damaging the distal vessel, but sometimes very useful in difficult cases.
Yeah. Yeah, I mean, I was asked to give 5 tips, so I had to end somewhere. But yes, those are very important techniques as well.